All right, so hello everybody. My name is Luke Haynes. I'm with Haynes Physical Therapy. You're here for our presentation of the rotator cuff and the shoulder workshop. We're doing this via webinar. Normally these workshops we do live and in person, and it seems to work quite well that way. Unfortunately, with the COVID-19 situation, the social distancing that we're all practicing right now, we did convert this over to this webinar format. So the quality of video hopefully is not terribly bad, whether on Facebook or on Zoom. We will provide some links to this information just a little bit later so that you can look at it again if you need to. I'll also mention that if you are one of the Zoom participants, there will be a chat button somewhere on your application. So if you've got a question along the way, feel free to send that question in. Ashley will send me the message and we'll see what we can answer as we move. So feel free to ask questions as we move through this. So the first question that I always ask on these workshops is anybody dealing with any pain? Specifically here, is anybody dealing with shoulder pain over the past 30 days? So everybody that came in to the webinar had a poll up front. So I'll ask Ashton to tell me how many percentage of the people had shoulder pain. 100%. So 100%. Obviously, unless you were just looking for some great information and nothing to do on a Thursday night, you probably are here because you're dealing with some shoulder pain. I'll let you know I'm also a member of the Shoulder Pain Club, so I deal with mine as well. So this is good information for me as well. So as we move forward, what I want to do is talk a little bit about what the rotator cuff is when we're talking about that with the shoulder. So what we frequently hear when people are talking to us is about our rotary cuff or something along that line. So I want to dispel, that it's not a rotary cuff, although I'll talk about that. But really, it's called the rotator cuff. And so let's talk first about the bones of the rotator cuff. So the rotator cuff is basically comprised of, the bones of the rotator cuff comprised of 4 bones. And we'll go through each of those. The first one is the humerus or the upper arm bone. You don't have to know the fancy words. The second one is the shoulder blade or the scapula. The third bone is the collarbone or the clavicle. And a part of the clavicle that sticks out over the edge, we feel it right here, is the acromion. And the acromion is very important for folks that are dealing with shoulder pain. So those 3 bones and then the acromion on the edge are basically the bone structure that comprises the rotator cuff. And so let's talk about the joint itself. So on the upper arm bone or the humerus, we've got the surface that combines onto the shoulder blade or the scapula. And so the interesting thing about this is what we call a ball and socket joint. So the upper end is shaped like a ball, and then on the shoulder blade, it's kind of like a socket. And so that's how those 2 joints work together to give the motion throughout the shoulder. And again, it is the socket. So it's a ball in the socket joint. The interesting thing about the shoulder, unlike say the hip or the knee or other joints in the body, very similar to think about the shoulder joint as the ball being a golf ball sitting on top of a golf tee. It's a big old ball in that little socket of that joint. And that structure is what gives the shoulder the most degrees of freedom of movement of any joint in the body. So it's a very versatile joint with a lot of movement. And so then let's talk about the muscles. There are basically 4 muscles that comprise the rotator cuff. We call them, clinically, we call them the sits muscles. And that's because that's the starting letters of the muscles themselves. The one up top is called the supraspinatus. More often than not, when we're dealing with a rotator cuff injury, it is the supraspinatus that we're dealing with. To a lesser degree, the one below is the infraspinatus. Now, as you can tell, these all come off of the shoulder blade itself, and then they move over and attach onto the upper arm bone right out here. And most of us, when we're talking about shoulder pain, we're usually going to talk about it right here. And partly that's because that's where everything attaches. The third muscle, and this is rarely involved, it can be at times, but because it attaches onto the shoulder blade and has a common attachment on the upper arm, we include that as well. That's called the teres minor. Then there's the fourth muscle, the rotator cuff. This one actually sits on the front side of the shoulder blade. And so it attaches to the side that sits up next to the rib cage, and then it attaches on the front side of the upper arm. So it attaches more in this area right here. So those are the four muscles of the rotator cuff. And so another important thing to think of when we're talking about the rotator cuff is everything working together. So with the rotator cuff, we have to look at what's going on in the neck, because very frequently we have issues in the neck as well if we're dealing with issues in the shoulder. So we have to deal with the neck, and that's everything from the very first vertebra down to the seventh. So we've got 7 vertebrae in the neck, and the one after that, T1, is where the first rib attaches. We'll get to that in just a second. But the second issue that has to work together is the collarbone. And the collarbone, because it is actually the only bony attachment of the entire shoulder to the body itself. Just that one little bridge of where it attaches. And so we also have the shoulder blade. The shoulder blade has to move correctly and do its job as well. Anytime we have a shoulder injury, that shoulder blade tends to be one of the first things that becomes problematic. And then we also have to talk about the rib cage and how it impacts the function of the shoulder. So those 4 areas have to work together in order for the shoulder to work how it needs to work. So normally in a workshop, I will have everybody that comes in to do this, they'll have a worksheet. And on this worksheet, I have everybody fill out the questions that we're talking about. This first one on the worksheet that we normally fill out is, what is the rotator cuff? Well, it's a group of 4 muscles, and what they do is they move the shoulder. They're responsible for everything that happens in the shoulder. The second question we ask is, what is the shoulder? It's a ball and socket joint. So that's important to know of how that joint moves around in there, and it's because of the type of joint that it is. And again, that's what gives it all the movement that it has. And then finally, the 4 areas that have to work together for proper shoulder movement. It involves the neck, the collarbone, the shoulder blade, and the rib cage. All 4 pieces have to function together well in order for that shoulder to work well. So normally I have a live audience, and I normally have people who are dealing with shoulder issues. I've got 2 assistants here who are really helping me out a lot right now. Unfortunately, their shoulders are fine, so I don't have anybody that I can do a live miracle on. So we're going to skip the live miracle. So who am I, and how did I become to specialize in shoulder and rotator cuff treatment? Well, let me go all the way back to 1985. Playing football in high school, I dislocated my shoulder on one play. Actually, what happened is I was reaching out to try to tackle somebody, and somebody landed on top of me. And I believe it was the right one first. And so dislocated the shoulder, took me to the sideline, relocated it. The next play, I went back in, and on my very next play, same thing happened again, dislocated the left one. So at 17, that's no big deal. You rub some dirt on it, you move on, and then it's not that big of an issue. Fast forward 20 years, then all of a sudden we get a little age on the body, and the joint is not moving like it should, and so that's where I started to develop some of my shoulder issues. And we'll talk a little bit more about that in a little bit. So a little bit more about me. I graduated from physical therapy school, Texas Tech, in 1994, so that's been just a little while. Shortly after that, I went on to, well, shortly after, just a little while, went on to get my doctorate in physical therapy from the MGH Institute in Boston, 2012, and that helped me learn a lot. But it was really everything, and I tell my new therapists coming in, I tell people what we really learn, where we really get our expertise is in what we learn hands-on in what we do after school. So I've gone through lots of training over the years and in different approaches and different techniques. 26 years into the profession, I still am learning new things almost every day. So it's an ongoing collaboration to continue to improve what we do. My achievements, I am the author of the neuromuscular dry needling approach. We use dry needling quite extensively in our treatments. It's not for everybody, but it is one of the approaches that we find to be very significant in getting some improvement in pain. Whenever we talk about people with, whether it's a shoulder problem, whether it's a hip problem, a knee problem, a back problem, we basically talk about there's 3 phases of healing. The first phase is we have to look at knocking down pain, knocking down inflammation. And that's where we use all of our tools. We'll demonstrate a little bit of what we do with some of our manual therapy here. It's kind of hard to do it with somebody that doesn't have problems, but we'll show you what some of that looks like. I also find that the dry needling piece does well with that. So that's where we use our dry needling. Before I get lost, the second phase of healing, it's important to know, is we have to restore normal motion. So anybody that's dealing with a shoulder issue, one of the issues is we have a hard time getting that shoulder to move up, and it jams right here. So the second phase, once pain comes down, is getting that motion back. Third piece is actually restoring your normal functional daily activities, and that's really what we do there. So anyway, with the dry needling piece, something I'm very proud of. I do a good bit of teaching across the state and for other clinicians. All of my staff I've certified in the approach. And then from time to time, I do some guest collegiate lecturing as well. So my clinical experience, again, I've been in practice for 26 years. I've probably treated or supervised over 500,000 patient encounters during that time. As far as specific to my dry needling approach, this is a little dated. It says 30,000 patients. It's obviously a little bit higher than that now, and probably close to 150,000 different dry needle applications during that time. And so let's talk a little bit about getting back to normal. What are the first steps? Well, one thing we want to know is are your symptoms reproducible? That's important for us to know. So we talk about traditional physical therapy. This is what we all learned in PT school over the years. You do your basic stuff. And so it's going to be hard for some of you to see this. But in our traditional approach to physical therapy, 25% of folks were treated very successfully, and they didn't need surgery, and they got back to normal and didn't have any problems. Through traditional therapy, there were 25% that they did poorly. They just didn't respond to what we were trying to do through traditional therapy, and their outcomes just weren't that good, and they still had problems and needed some sort of other intervention. And so then there was another 50% that their response basically is it did okay. Therapy seemed to help get me stronger, but still had problems, and they still had questions about whether they needed therapy. Whether they needed surgery. And so that's what traditional therapy looked like over the years. In a lot of places, that still is the situation of this. Quarter people do very good, quarter people don't do very well at all, and the other 50% are just kind of ho-hum on the whole experience. So what I've introduced into my practice is a lot of innovative approaches to dealing with the rotator cuff. Because I'm also a member of the club, it was important for me to learn how to deal with it effectively. So we talked a little bit earlier about treating all 4 systems. We talked about treating the neck, about treating the collarbone, about treating the shoulder blade, and then the rib cage. So traditional physical therapy didn't look at all of those systems. When we start integrating those pieces into the system, now all of a sudden our outcomes look significantly different. So now when we're dealing with a rotator cuff shoulder pain issue, 90% of those folks are treatable without surgery, and they get really good outcomes. Now, there's definitely 10% of people, there's no way getting around it, you're going to need to have surgery. But for the vast majority of folks, myself included, I was able to, so let me back up a step. I actually did end up having surgery on my right shoulder. I really needed surgery on both. I had the rotator cuff repaired. I had a few other issues going on in there. So I had to repair it. I'll be honest, I was a terrible patient. I pushed myself way too fast, and I re-injured it within a month or so. And so that was 8 or 9 years ago. And so what my quest has been since that time was how to deal with it so that I could avoid any more surgery. And so I can now do anything that I want to. I will never be a pitcher for the Rangers or the Astros or anybody else, but actually that's not what I do anyway, so I'm not worried about that. So what I want is minimal pain and to be able to do anything that I need to do. And using my approach, I definitely fall in this 90% category. So coming back to this issue of reproducible, is your pain reproducible? So when we look at any problem again, whether it's a shoulder, whether it's a knee, whether it's a hip, if we can reproduce what's causing your pain whenever it happens, then there's hope, because we can change whatever is happening to make that happen. We'll talk a little bit about some imaging and things related to tears and so forth. But that's our question is, can we reproduce that clinically? Can I make that shoulder hurt the same way again? Because again, if it is, we can go address those 4 systems and make some really nice change and impact there. And so forgive my computer business here. The nice thing is if it's reproducible, then it's reducible. I know that's kind of cheesy and corny, but that really is what we're looking for. If we can find what's causing that pain, then we can affect a change on it. So back to your non-existent worksheet that you would have if you were live here. The first question, if your pain, numbness, or tingling in your arm is reproducible, then it's reducible. So if you will, pull up that next poll. So actually, it's going to pull up another poll in here. And there's going to be 2 in here. The first one is going to ask, in the past 30 days, what was the worst pain you've had? And in that, I just want you to rate it from 1 to 10, what the worst amount in there. 1 is very minimal pain. 10 is your worst imaginable pain. The second question, actually in your case, it's going to be the first question, is what were you doing when you have that pain? Were you sleeping? Were you reaching overhead, lifting something? Very common, pulling a gallon of milk out of the refrigerator, putting your hand in your back pocket, putting your hands behind your back to put on your bra, fixing your hair, getting up from the floor. There are lots and lots of potential things that you can do with the shoulder that can create issues. Sleeping is a big one. A lot of people sleep on their side with their arm up here, and that's for a person that has a shoulder issue, that's one of the worst things that you can do, simply because of what happens to those muscles when you do that. So if everybody's had a chance to put some numbers in there, I'm going to play the Jeopardy song just momentarily. Can you sing the Jeopardy song? Nope. Nobody's singing the Jeopardy song. So I'll tell you what happens with mine. In the past 30 days, the worst shoulder pain I've had was maybe a 2. I really haven't had any bad shoulder business going on. Again, I treat mine on an ongoing basis so I don't have to. And my pain was, my pain tends to be more if I'm reaching out and back behind me. That's where I tend to aggravate mine the most. So, do you have any data for me?
5 people have answered the poll so far.
Okay.
Our pain ranges from a 1 all the way up to a 7. And it looks like we've got a little bit of everything.
A little bit of everything.
Probably the worst is reaching overhead. Several sleeping issues. Getting milk from the refrigerator.
Yep.
A little bit of everything.
So the challenge with the shoulder is because it's so important in everything we do every day. We can have back pain, but I mean, honestly, and I do a workshop about back pain, we can put up with the back pain for a long time before we actually deal with it. When we're dealing with the shoulder, we have to use our upper extremities on everything that we do. So having issues with the shoulder becomes a little bit more significant. So, all right. And again, on this reproducible issue, if there is a cause when this stuff happens, there's something happening when you're sleeping or reaching overhead. And so there's a mechanical thing that's happening. And when that happens, we can elicit a change there, and then there's hope there. So really briefly, I'm going to talk about the cause of a problem. And this isn't necessarily related to just rotator cuff or shoulder problems. So 3 things that we can do. The first thing we can do is we can ignore it. And so the analogy that I use is potholes in the road. So where I live, the roads are rather bad, and they always get ignored, and so it's pretty rough going up and down that road. So one thing that they can do is they can ignore it and not do anything about it. So what does that relate to? Well, that relates to shoulder pain. Well, it hurts. We can pretend like it's going to get better in a day or two. If it does, fantastic. But if it's persistent, then ignoring it doesn't necessarily keep it at bay. The second thing we can do is we can alter it. Now, frequently back to the pothole analogy. So God bless them, they can get out there and they can put a little asphalt there in the hole, and they can fill it in a little bit, and that'll last a little while. But as we all know, it's going to end up getting washed out again anyway, and it's not going to really change until a little bit later, until they deal with number 3. So here in the shoulder, the rotator cuff, what that looks like is dealing with drugs, injections, surgery. They're going to alter the pain. They're going to alter what's happening in that shoulder. But what we'll talk about it, what really is at issue is the mechanics of how that shoulder is working. So if there's an issue going on in the neck or in the rib cage or in the collarbone that's causing pain in the shoulder, you can go repair that shoulder and make some changes there, but it's not going to change the mechanical piece of what's happening. And that's the critical part. Which gets us to thing number 3 that we can do, which we can handle it. And that's what we're here to talk about. So here on my pothole analogy, about the only way they can handle those potholes is to repave that road. And that's about how we can take care of the road situation. For dealing with the shoulder and the rotator cuff, the best way to deal with that is just to get some natural treatment and learn how to manage your symptoms. So, again, back to our worksheet that you don't have. Things to do when faced with a problem. Number 1, the single biggest mistake shoulder pain sufferers make is they ignore it, thinking that it's just going to get better and take care of itself. And the 3 things that you can do about your, well, that says low back pain, but for your low back pain and sciatica as well, this will work. You can ignore it, you can alter it, or finally, what I'm advocating is learn how to handle it. And so let's talk a little bit, 3 main causes of shoulder pain. So before I do that, a quick discussion of imaging and what does normal look like. A normal x-ray of the shoulder, again, we talked about the upper arm, the collarbone. Here you can see the rib cage, and then the shoulder blade that's coming here, and then the acromion out here. We don't see any significant spurs. We don't see any crazy stuff going on in here. So that's what normal looks like. The secret is, over the age of 50, most of us, a very high percentage, are going to have some tearing in our rotator cuff. We may have some bursitis. We may have some tendonitis. Those things are going to be there. That's a function of age. That's a function of use. But it doesn't necessarily mean that we have to go have the injections or we have to have surgery to correct it. And I'm the perfect example of that. So that's what normal imaging looks like. So we're going to talk a little bit here. MRI studies of adults with no shoulder pain show that 20% have partial tears, 15 have full thickness tears, and again, here at 60 and over, full 50% had absolutely no shoulder pain, but they had injury to the rotator cuff with tears on their MRI. They didn't even know about it. So we talk about that. The translation down here is if you get some imaging done, there's some tearing, there's some pathology in there, you don't need to panic. If your imaging shows rotator cuff tear, it's not necessarily associated with your shoulder pain. Imaging is a great tool, but we have to be careful. We have to be careful of the vomit and the barf. So what is vomit and barf? Vomit, I didn't come up with this. Vomit is being a victim of modern imaging technology, and barf is a brainless application of radiological findings. Why do we advocate? Or what is that? That's treatment based solely on imaging findings without any clinical correlation. A good surgeon friend of mine tells me, and he's told me this for years, we don't treat this picture. We treat the patient. We treat the person. Because treating that picture may not solve the problem. So back to the 3 main causes of shoulder pain. Number 1, surprisingly, it's a neck problem. A lot of times, especially as we get a little bit older, our neck changes a little bit. A lot of the issues in our neck are going to radiate out laterally towards our shoulder, and we have to look at those issues. So these are things such as stenosis, arthritis, degenerative disc disease. In that, with stenosis, the spine, the vertebrae themselves start losing height, and it starts to compress on the nerves that are coming out of the neck. So here we are. So this image is of looking, so this person is looking directly this way at you. So here we have the vertebra on either side. In between is the disc, and then we have the nerve coming out to the side. So these little gray areas right here are the stenosis or the arthritis. This disc will have lost some height over time. So the net result of all of that information is that we start to get a little compression on this nerve right here, and because the nerves in the neck are what transmit our sensation, our motor, our power out to the shoulder and the upper extremity itself. Whenever we have these things going on, that's where we start to get some compromise, is there. And so, again, we talked about some of the imaging here. So this imaging is looking straight on right here. The second image is taken from the side, and this demonstrates that as well. So not only can the nerves coming out to the side be compressed, but we can also get the spinal cord itself can start to get compressed. And that gets especially important in the neck because of how those nerves run down the rest of the body themselves. We'll talk about this on problem number 3, but you see this person is sitting nice and tall, their posture looks really good, and that erect posture does a really good job of reducing this compression that can happen either on the side or in the central canal. And I'm still associating into the neck, the rib cage or the first rib especially. So the first rib can be a problem for a lot of people, especially if you are a side sleeper with your arm under like this. What that does is over time, as you're sleeping at night, you can wake up and that rib can actually act almost like a bucket handle. So that thing sits very high. And the reason that gets important is, one, that area of the body starts to not function properly. The bigger issue is it decreases the amount of space where the nerves that are coming out of the neck, we call it the brachial plexus, they travel between this first rib and then the collarbone that we talked about. So that first rib can come to be a real issue whenever we're dealing with pain out in the shoulder. And so here's just a little example of that. So this very first rib, if it gets elevated, then it becomes a much less amount of space for these nerves to travel down. And again, a lot of the sensation, a lot of the power comes through these nerves right here. So not only can we get compression where they come out of the neck, but if mechanically we're not moving correctly, it can impinge on those nerves even further out here. In some extreme cases, we can get something that's called thoracic outlet syndrome, where you see different things going all the way down the arm. So that first rib becomes important. What happens with the neck issues? Well, we get limited range of motion in the neck. And in the neck, really 3 different planes of movement. We have the flexion and extension, which is just up and down. And we have the rotation, which is looking left and right. And then we have the side bending, which is just ear to ear. So one of the first things that we look at with somebody that comes in with a shoulder problem or rotator cuff injury or issue is, what does the neck look like? What does their motion look like? Because if we just go deal with that shoulder, we're missing a big part in what's happening with the nerves that supply that. So the second cause of shoulder pain is something that's called impingement. Now that's a fancy word to say that there's not a lot of space in here and things are getting jammed together. So with impingement, and I'm coming back to the picture of the muscles here. So this upper rotator cuff comes right through here underneath the acromion that we talked about and attaches way out here. Well, it's kind of hard to see right here, and this is a healthy one, but there's not a lot of space in there for that muscle to come down through there. And so what impingement means is, and you can see over here, that's a bursa, and a bursa is just a sac of fluid that protects the upper arm bone from jamming onto the acromion right here. So if you fall and land on it, it's there as kind of a shock absorber. But what happens if the rotator cuff gets, the upper especially, gets irritated, inflamed, anytime something gets inflamed, what does it do? It swells. Well, when that muscle swells a little bit out here, if the bursa is irritated and it swells, then all of a sudden, we don't have a whole lot of space out here for this thing to move accurately. And the end result is we lose our normal mechanics. And so that irritation, especially if it goes on long enough, can lead to a loss of function and can lead to some small tearing out in the muscle. So impingement is incredibly important in identifying that. So where do you see that? People can have trouble reaching behind their back. Again, the side sleeping on an elevated arm. As we talked about, the spacing get very small. As we get a little bit older, a little bit of some arthritis in there, then we start also getting bone spurs. It's hard to, so here's the collarbone coming over right here as it attaches onto the shoulder blade out here out at the acromion. By far the most common place for bone spurs is right here with what we call the acromioclavicular joint or the AC joint. And what happens is that bone spur comes directly down and can connect onto this muscle. Well, it acts almost like a little knife every time you move. If that spur gets too aggressive, it can actually cause the tear there. It gets worse if you fall on it, and it can jam and pierce that muscle. So again, that comes back to looking at the four different phases of treating the neck. One is the collarbone. We have to make sure that that collarbone is moving well and doing what it needs to do. And so finally, the third main cause of shoulder pain is poor posture. I'm going to get my helper up here. I'm going to have you just sit right here. We don't have to turn that off yet. So poor posture becomes incredibly important. Actually, let me have you sit right here, facing that way. Okay, so poor posture of the neck especially. So sitting in that position, the posture looks really nice. If you will, let me have you raise that arm like such, and this one, then do them both together. Okay, so good motion, everything looks good. Now what I want you to do, I want you to slouch. Way down. Okay, now I want you to do the same thing. And then the other arm. So right there, that tells us that posture is incredibly important. Very good. You get up. So most of the time when we're dealing with a shoulder issue, we're also dealing with a posture issue. And so person coming in to see me, one of the first things I want to address is, number one, what is the neck doing? Because if a person comes in and they've got this business going on, which we're all guilty, we spend our lives here or doing whatever we do here, and we spend all this time here. Well, if we've got a shoulder issue going on, even if we don't, we've got to get that head back. We've got to get normal posture again, because that makes a big difference between being here and lifting those arms up or here. And I'd encourage you, try that at home. You know, go to a slouch position and see what happens versus sitting up tall. It makes a huge difference. So posture becomes incredibly important. Though it's a simple thing, and that's something that a person can work on their own. Unfortunately, we're human beings, and a lot of times we don't work on it on our own. So just a little graphic here. So with good posture, the head and neck is sitting straight up tall. There's about 10 to 12 pounds of force coming down through the 7th cervical vertebra here. If we move our head forward even 15 degrees, all of a sudden that force through there jumps up to 27 pounds. Moving on up, if we're really slouched out here, what at one point was a 10 to 12 pound force through that vertebra now has jumped up to 60 pounds. And the reason that's important is that force is going to be translated primarily through the 7th cervical vertebra, that one that sits right here at the base of the neck. And whenever that happens, because it's so close to the first rib, our posture is going to come down, and we're going to start having all these other related issues, the first rib on the collarbone and the pain coming out to the sides. So again, another example of working on that posture. Hopefully everybody stood up and tucked their chin in when I mentioned that. And so, yeah, and we just demonstrated that slouch position. So back to the worksheet that you don't have, the top 3 common causes of shoulder pain. Number 1 is a neck problem. We've got to look at that neck and see what's going on there. Number 2, and that includes the first rib. Number 2 is impingement. This business that's going on out at the acromion and underneath there. What's happening out there? And then third, finally, is posture. We have to address that posture to make the change in changing mechanics in the shoulder. So what does successful natural treatment look like? So again, normally, if you want, you can kill that. Normally I've got folks here who are having some issues, and what we'll do is find somebody with a problem, and I'll go ahead and do a little quick treatment on them to show you how quickly we can make some changes, if you will. Actually right here. But since my subject, thank you for coming, doesn't seem to have any issues except if she has poor posture, then one of the things we'll look for, first off, if there's dealing with a cervical or a neck issue, we may come in and do some manual therapy on the neck. Now that will normally be done in lying down to deal with that. We can address each of the vertebra in the neck in that way with some manual therapy techniques. More often, we deal with that primarily through our posture and education on that piece. When we start moving out, one of the bigger issues is dealing with the first rib and then the movement of the shoulder blade, on how it impacts the upper arm. So when we're talking about the first rib, we're not talking about a hard, aggressive, manipulative force. There are times when it's necessary, but more often than not, we can apply an easy approach. So let's say, for example, that she has a left shoulder issue, and I'm curious about this left first rib. So one of the things that I might do, I'm going to bring her over to this position, and just very gently, I'm going to have her push into my hand, just going to hold it a few seconds, and then we're going to let it relax. Okay, I know it seems very simple, but it can be very effective, and then we're going to go again. So this is what we call a muscle energy technique. It is a very simple approach to use your body's own natural systems to make some relaxation here. If that doesn't happen, then what we can do is come in and apply more direct force. So in this case, I may come in. Again, I'm not doing a manipulative approach. It can be done, but usually just a little bit of some easy movement on that first rib can make a big improvement there. A lot of folks dealing with shoulder rotator cuff pain are also dealing with stiffness in the whole upper quadrant themselves. So a lot of times what we can do is just come in and just start moving this shoulder blade around. Because more often than not, the longer it's gone on, it will have gotten very stiff and limited with its movement. We can do it that way. We can get a little bit more aggressive, come around and give it a little bit of a stronger approach right there. And then ultimately the idea is we want them to be able to keep that shoulder blade down as they start working here. Because that is the key. A person with an injury or pain in the shoulder, the issue is the whole thing's going to elevate as they lift and do this number right here. If you've dealt with a shoulder issue, you know exactly what I'm talking about. That right there. A lot of times I mention the dry needling. Shoulder responds very well to dry needling. It's not for everybody, but we get very good results dealing with the rotator cuff, dealing with impingement, especially when we're dealing with these structures here. We can make some vast improvement by using that approach. Okay. We'll turn that back up. So, and that was a very fast approach, but in that short amount of time, I was able to look at what the neck is doing, what the first rib is doing, what their collarbone is doing, and then what posture is doing. So, and those are the important things. And so that's really in a rapid approach what successful natural treatment would look like. So what does it look like? It's hands-on physical therapy. If you're going to see a clinician right now and they're working with you on your shoulder and they're not putting their hands on you to move the shoulder and the surrounding structures, that has to happen in order to restore normal movement, normal mechanics of that. The second piece, you've got to do some stretching and strengthening specifically of the muscles so that you can retrain the muscle memory. Again, we get into this habit with shoulder issues of raising that whole thing up. Well, we've got to get the right muscles moving correctly with the right strength. The coordination of those 4 rotator cuff muscles has to work very well. Like I said, we showed the golf ball on the golf tee. It's a very loose, very mobile joint, and it requires all of those muscles to work in concert in order for that to be stable and to move how it was intended. And then finally, for successful treatment, we need something to deal with. We talked about the 3 phases of healing. To deal with that first phase, if pain is staying extremely elevated, 5 and above, then very well we may need to be dealing with some dry needling or something that's called a class 4 laser. A class 4 laser is been around for a long time in the veterinary population. It's fairly recently that it's been approved by the FDA for us to use it on humans. We do see some good results with both approaches. Not everybody needs to have those things, but if that pain cycle has to be broken, you need something a little bit more vigorous and aggressive to get after that. So at this point, I'm going to turn that piece off. Very good. So at this point, let me tell you a little bit about what my offer is. You fine folks have braved the COVID-19 to sit in your homes or wherever you're watching and paying attention to listen to me ramble on. So you should feel good because this is 46 minutes worth. I can lecture for 8 hours at a time, so I've kept it really short here. So I appreciate you coming on and listening to what I have to say. What is my offer? So I want to offer either a free consultation or a full evaluation. Now, you've come on board and you've listened to me ramble, so I'm going to offer a free consultation to anybody that has been on this call. So down at the bottom of your screen somewhere, if this is something that you're interested in, there will be a chat button. Feel free to get on there and submit and say, hey, I'm interested in coming in. What do I need to do? And we'll bring you in and just do a free consultation, just a free look at what's going on. What you get on that is I'm going to look at certain movements. I'm going to feel your shoulder, determine what might be causing your rotator cuff and your shoulder pain. In that, we want to find out if there's something that can be done to heal it naturally. I'm going to give you some tips on some things that you can do. And at the end, if you decide that you want my help, then so be it. But I'm not a high-pressure salesman. I'm not trying to force you to decide I want to do this, I want to do that. If you decide you want to continue to ignore it or alter it, then you get to make that choice. So is there also a poll? Yes. So we're also going to put up another poll here. This just has a single question. So before we get completely to that, or is it already up? All right, it's already up. So let me tell you a little bit about the difference between, while you're looking at that poll, the difference between a free consultation and evaluation. Well, a free consultation, exactly that. It's free. I'm going to take about 20 minutes, and I'm going to determine a potential cause of what I think might be going on. We're going to talk a little bit about it, and we're going to talk about what successful treatment might look like. I do a lot of these, and they're very helpful for people. I'd say 75% of the folks that come in for a free consultation end up converting over to a full physical therapy evaluation. And so what does that look like? So here, I'm going to do a full evaluation. I'm going to go through, we're going to identify what is the cause of this. We'll look at the neck, we'll look at the rib cage, we'll look at all the structures that we talked about, and we're going to see if we can't figure out what's going on and what mechanically we need to do to alter this. And I want to find that 90% of folks and see if we can't make some real changes for your rotator cuff issues. Like I said, 10% of folks are still going to probably need some surgical intervention. But 90 versus 10 is a big difference. So after we do that, then we're going to go in, we're going to apply a successful treatment, whatever that looks like, whether it's a neck issue, whether it's a posture issue, whether it's an impingement problem. We'll go ahead and apply that. That can take anywhere from 45 to 60 minutes. At the conclusion of that, we're going to sit down and we're going to figure out what a plan of care to treat your condition might look like. There are some times I have a person come in and I might just need to see them once or twice and we can take care of a problem. But I'm going to be honest, it takes a little bit more than that, especially if this problem has been going on for a while. If you've been dealing with this issue for an extended period of time, it may take several weeks to get the body to change its normal routine, its habits, and for you to regain the strength and the normal mechanics that you need for a shoulder problem. But that's what the evaluation is for us to figure that out and to develop that plan of care. So, were there poll things that I need to explain? Okay, so, and I do have, listen, right now I've got 10 slots available for a free consultation, 5 slots open for a full physical PT evaluation. And if you want to indicate that in the chat section at the bottom of the screen, please do that. If you have questions, that you can send those for the moment through the chat session. And if you want more information, our information is there at our email address. Online, you'll find us at hainstherapy.com, or you can give us a call. There's a lot of ways you can reach out to us. But if you need more information, just reach out and we'll see what we can do to help you with your rotator cuff and shoulder pain. Thanks for tuning in.